the way that this is going to run is our panel of experts, they're going to speak first, and then we're going to have a question and answer period. So anybody that would be in the crowd, Sarah's going to go around. You'll have a microphone. Because this is going to be on Armstrong cable, please speak into the microphone, during that portion as well. I do want to thank Ohio University for hosting this. This is a beautiful facility. And also Armstrong Cable. Starting this weekend, this will be on channels 4 and 100, and it'll also be on the Armstrong YouTube channel, as well as on the website for the Tribune as well. So a couple introductions, and then we'll get going. We'll start with Sheriff Lawless, Jeffrey Lawless. Then we have Andrea Boxill, Todd Davies, and Andrew Ballard. Before each of them speaks, I will have them introduce themselves so that you know exactly their backgrounds a little bit as well. Sound good? All right. Sheriff? How do you want to do it? How about you introduce yourself first, and then we'll start to speak.
Good evening. I'm glad to see a great turnout. Wasn't sure what kind of turnout we'd have on such a beautiful evening. It's hard to get people to come in out of the sunshine after the winter and spring we've had. But thank everyone for being here. I am Sheriff Jeff Lawless with the Lawrence County Sheriff's Office. I've been with the Sheriff's Office or in law enforcement for coming up on 32 years. Most of that time has been spent with the Sheriff's Office.
And I'm Andrea Boxill, Deputy Director of the Governor's Cabinet Opiate Action Team with the Ohio Department of Mental Health and Addiction Services. Prior to this, I started all of the specialized docket programs in Franklin County Municipal Court, which included mental health, drug court, and opiate court, victims of human trafficking court, as well as a military and veteran services court. And prior to that, for 13 years, I was doing work with juveniles who I'm now seeing as adults in the justice system.
I'm Todd Davies. I'm the Associate Director for Research for the Division of Addiction Science at Marshall University. I am an addiction researcher. I work mostly with pregnant women and babies who've been prenatally exposed to a variety of substances. A lot of the work we do at Marshall is centered on this population that we have a pretty significant amount in Cabell County and here in Lawrence County. We see a lot of the babies that are prenatally exposed. We work a lot with their moms. We work a lot with families and a variety of issues surrounding substance use disorder.
And I'm Andy Ballard. I'm one of the common pleas judges in Lawrence County, and was elected in 2016 and been dealing with a docket that is overcrowded with drug cases. The majority of crime that is now being brought forth before the court in Lawrence County has a drug-related component. We estimate, if you count even the offenses of violence that aren't directly indicted or brought before the court on an information on a drug charge, there's still an underlying addiction problem in more than 90% of the cases that we're dealing with right now. We've instituted a drug court that is awaiting final certification from the Supreme Court, but we're up and operational. We're trying to take a productive approach, something different to the situation that we are faced with now, because the theory that is going through the correction system as well as court system is that the situation we're dealing with is partially created by years and years of cookie cutter approach to sentencing and how we apply justice in the courtrooms. And what we have seen now through overwhelming numbers and research is that prison is not necessarily a place to expect rehabilitation to occur. So we are trying to do different innovative approaches within our court to tackle the epidemic from our perspective and the small percentage of the population that we deal with on a daily basis, which those have been brought forth in front of us on felony charges. all the while figuring out how we can have more of an outreach into the community and be part of the community, both individually and through the office of judge, to help the overall problem in the community that we're facing, which is a much larger component than the small section of felony offenders that we're dealing with daily.
I'm Sarah Simmons, and I'm a community outreach leader at the Ironton Tribune.
And I'm Scott Schmeltzer, and I'm the publisher and president for the Ironton Tribune. So we're going to get started, and I think the perfect person to maybe start this would be Todd Davies.
Okay. Well, maybe we should just talk about what addiction is, right, and how it functions. You know, we hear a lot about people who have substance use issues, and the addiction pathway, and when you talk about brain chemistry, is the same no matter what you're addicted to. Maybe it's opioids, maybe it's methamphetamines, maybe it's caffeine, maybe it's sex, maybe it's shopping. The addiction pathway is the same. The problem with opioids specifically is that pathway operates through the dopamine pathway, which is the mu-opioid receptor, which is the receptor that opioids bind to. So what happens when somebody is in active addiction? So normally, if you're having a good day, right? It's a sunny day. Maybe you're off work. Your things are going really well. You won the lottery. You've got an operating dopamine level at about 100 nanograms per deciliter, right? So that's the high for most people. If you're having a bad day and it's gray and it's maybe you got fired from your job, things are just terrible, then you're down around 40 nanograms per deciliter. So we all work within this range normally as we go through our day, days and weeks. And this is the range for a typical operating brain in terms of dopamine biology. What happens when you get that first dose of heroin is you jump to 1,000, right? So your happiest memory, indicated by 100 nanograms per deciliter, has just been bleached out, right? And as you continue, right, as an individual continues that, the opioid exposure, and this does happen with other drugs, including marijuana, despite what people think. As you get that continued exposure, all of your positive memories, right? Now, you still have memories, but the positive feelings, that dopamine response associated with those memories goes away. So you can remember everything, but you don't have that good feeling you used to have when you think about that particular memory, right? And so as the use continues, that number drops and it drops and it drops and it drops until you're down around 15 or 20 nanograms per deciliter when you're not using. So now it's no longer about getting high. It's about just not hurting, right? 15 to 20 nanograms per deciliter, that's major depressive disorder. That's the worst flu you've ever had. You can't get out of bed and you hate the world. That's how low that is, right? And so when I hear people say, why don't they just quit? Well, because their brain chemistry is operating at a level that is just sheer pain. So what happens is that they're just trying to keep the pain away at that point. Just trying to keep the pain away. So we get them in treatment, right? And when a person is ready, and people that have been through recovery tell me all the time, it takes a while. It takes a while to think about it. You're stepping in and thinking about, well, I'm going to go back to a, quote, normal life. You're going back to an area that now you no longer have positive memories associated with, right? All that's gone. So now when we get them when we get these folks into treatment, getting them back to that area. This is why we talk about medication-assisted treatment, right? Because the Subutex or the methadone is to get that person back into that normal range so that cognitive and behavioral therapy will work, right? So you can start talking to people, so you can start learning. Now, a lot of people don't need it. A lot of people can detox, right? And their brain chemistry will adjust. But there's a large number of people who their dopamine responses don't adjust anymore, right? To get back into that normal range, they need help. Now, once we get them back into that range, that's not enough, right? We haven't cured the addiction. All we've done is now we've got them receptible, to where they'll take in therapy. To now we can just now start having those conversations, right? We've dealt with the brain chemistry. Now we can just start having those conversations. And it takes at least 90 days of intense counseling to go from, okay, now my dopamine responses are good, to get to a point where patients start getting responsive to the therapy in the first place. And that first 90 days is all about contingency management. It's all about, and what I mean by that is, when you do bad things, there's going to be a bad result. If you do good things will come of that. And it's that simple. After that 90 days, then it becomes all about helping these individuals rebuild their ability to have relationships, right? Because that's where most of our positive dopamine responses in our lives come from, right? You don't remember what conversation you had with people, but you do remember how they made you feel. And that's what builds us. That's what builds our ability to interact with each other. That's what builds our strength in terms of who we are and our sense of self. So as we rebuild and as we think about this, if all your positive memories are gone, right, your executive functioning, your ability to make positive decisions is like it was when you were in middle school. And how long did it take you as individuals, or if you have kids, I have a kid in middle school now. I hope he doesn't take too long. How long did it take you to be able to make smart decisions, right? You remember what it was like being a teenager, right? It takes a while. And it takes a while of having a support structure and building a strong social network of people that you can trust that are going to help build those positive memories for you and with you. It takes years. So when you say, well, why don't they just stop? Well, they can't. Not without some help. Now, you have all these sensitive people, right? You have them where they're going through and they're rebuilding all of these structures and rebuilding their ability to communicate with other people and build their social network. What do you think it's like for those individuals that are already having trouble when they go into the hospital and the nurse calls them a junkie, right? Or they walk into the store and they're getting dirty looks and people are passing them by. You're throwing up walls. We all do it. We've all done it. But when you throw up these walls, and we throw up these walls as a community, right? What we're telling these individuals is, no, this is too hard for you. I know you need, they need this social network, and the more we can enhance that as a community, the faster we're going to be able to deal with this epidemic. This is a social disease. It's not about abstinence. It's about being connected. It's about being connected to other individuals. It's about being more connected to your family, and it's about building healthy social relationships. So when we think about addiction, that's what addiction is. It's not just this bad activity. It's not a spiritual problem alone. It's a biological problem. It's a community problem. And it's a lack of connectivity with themselves, with their faith, with their families. The long-term effect and the way we can attack this as a community is helping build those social systems. And that's the key.
Thank you. Andrea, did you want to add anything?
Yeah, I think that's one of the better explanations, especially when you bring in the scientific component. And sometimes for most of the population, understanding the science is the most difficult, which is why we tend to, as a culture, historically, and even currently, will say this is a moral flaw, a character deficit, and therefore a choice. And so what I do a lot of times is I tell of myself and my own personal, right? And so my mother had cancer on the spine, the skull, and in her lung, but my mother also smoked, right? So by the theory of people choose, this, then essentially you would say my mother chose the disease of cancer, right? Just as you would say of a person who has heart disease, who has been told by their doctor, here is your treatment plan, here is your medication, I need you to lose weight, I need you not to overeat, I need you not to have alcohol, I need you to exercise. I need you to decrease the amount of stress in your life. And yet we may turn around 2 weeks from then and we see that person at a barbecue slamming, because I'm an eater, right? I don't miss meals, you can see it. But we would never say to that person, how dare you? You dirty such and such. But we are really quick to do that when we deal with the disease of addiction, because it's easy. The other thing that we don't like to deal with the disease of addiction, and very similar to the disease my mother had of cancer, is what we call social determinants. My mother grew up right next to the Mead in Chillicothe. She was born in her house because her mother and father did not have insurance. There were 7 siblings in her home, a 5-room home with 2 bedrooms. Drinking was commonplace. Smoking was so these are what we call social determinants. What is a social determinant in Ironton? Lack of employment, toxicity in terms of chemical. We have to deal with that, right? Perhaps loss of employment by a family member, which then means the stress that the family deals with. These are all factors that also lead to the disease of addiction. And they become worse if there is a family member who also already has the disease. We haven't even talked about physical, sexual, or emotional abuse, which again compounds the likelihood of the disease to grow. So when we start peeling away at the onion to get to the why, it's really easy for us as a culture to say, he chose it, she chose it. He just told you what happened to the brain and the specific receptor, and he didn't even go into what happens to the frontal lobe. And the fact that at 18, the part of the brain that's supposed to be developed fully with logical thinking, which tells you right, wrong, actually isn't fully developed at 18. So I just want you to walk away with one piece tonight. This is science. This is science. When you're given facts and when you know better, it's incumbent upon you to do better and to not continue perpetuating myths, lies, and misinformation. You don't get a degree based on guesses, I'm assuming, because if you did, I'd be a doctor.
I don't know, I guessed a lot.
Right. Use the facts, use the data, and use the information that's going to be shared with you, not just tonight, but every time you're out in the community, and also understand that this is a human condition, and parallel it with the disease of diabetes, of high blood pressure, of heart disease, because all of these, by definition, are chronic progressive diseases that can ultimately lead to death. So is the disease of addiction.
How would you answer one of the myths out there that people are asking, that this problem is only in trailer parks and the projects and low rent and people that are poor? Is that a myth?
And I think the judges and everyone in here can answer this. So I will admit to this. This is not even the 3rd time we've had this epidemic in this country. This is the 5th time we've had this epidemic. It goes back to even at the Civil War when we were giving morphine to folk who had been hurt. But as you stated earlier, Judge, good intention. We were dealing with trauma and pain. And then the next time we had it was actually during the building of the Asians building our railroads. And we have to be honest. You can't move forward with a crisis like this without truth and reconciliation. The reality is we didn't care because we got our railroads built, right? And the next time we deal with the epidemic is the 1914s with the Harrison Act, which is going after doctors who were over-prescribing primarily to women, who then neglected their babies. And so the Harrison Act actually prosecuted, I think it was around 3,000 doctors for continuing to prescribe, but most of those physicians were saying, we're at maintenance dose. And what do we hear now? We need to give them a maintenance dose so that they don't go through extreme withdrawal, making poor decisions. We need to get them to a level of functioning. They were prosecuted. To this day, the majority of professionals that I've come across who do not like working with the disease of addiction are physicians. They choose to stay away from addictionology for a specific reason. The next time you deal with it is the Harlem Renaissance. And again, we didn't care because it was brown people. We have to be honest. And the final time we deal with it is after the Vietnam War, when it was poor Appalachians and people in the urban environment. And we didn't care. We criminalized it and said we have to lock them up. And I have had probably several discussions we were sharing with the Otafka saying, please do not say we can't incarcerate our way out of this, because that's a lie, because you did it with crack. We have the most profitable prison and jail system in the world because it makes money. What we have to do is be honest and say, we don't want to do that, because now we acknowledge it's a disease and the person standing in front of me is sick. Now, with that in mind, this most recent epidemic, I can tell you I was running the drug courts and I had a prosecutor come forward and say, you have to do something different for pills. And I was like, no, we treat the disease of addiction. We look at the pathways and the And the person actually said to me, this is true, their parents vote. Do you know what that means? Their parents have an income that affords them being able to leave work for 2 hours to go vote. And I'm running. So you need to get this taken care of. And so it was very clear, get it, and I ran it. But then as I started researching, there is something different about this specific drug, just like there's something different about meth that we all need to be prepared for. And so, yes, originally it was because it was middle-class, suburban, and rural kids. But now, guess what? It's everybody. It's everybody. It used to be we would look at age of onset of use to look at propensity to become addicted. I'd say if you started drinking at 14, smoking at 10, I'd look at that. Now, you can be a 20-something-year-old high-functioning individual who got turned out because you got your shoulder hurt, but you never dealt with the trauma from childhood. And the painkiller only knows one thing, to kill the pain. Not, this is pain from physical or this is pain from childhood, just kill the pain. And so now when I say everybody, I saw one of the questions was, is it primarily poor people and African Americans, or is it just now that we're making it different? The reality is, based upon prevalence and incidence compared to population, so the African American population only makes up 12% of the state. They are 300 times more impacted as a result of having a smaller population. But the majority of the overdoses are white. The average age is still between 34 and 44, according to the data that we have. But it really is split pretty much down the middle in terms of male and female. Economic is all over the board, because you have to remember some people actually still function while abusing opioids, whether that's a pill or heroin.
Now, I haven't seen the data from Ohio, but I know in West Virginia, at least in Cabell County, if you look at the number of overdoses that we have, about 20% are women over the age of 50. So grandmothers. So it's everybody.
And case in point to that, I have a friend who's a physician at Cabell Huntington Hospital, and she called me one evening and asked if I could come over, and I was tied up and I couldn't. And she said I was going to probably break about 30 different hospital rules and put my license at risk, but I was going to have you come in. She was treating simultaneously 2 patients, a 68-year-old male and a 22-year-old female. That same night, both dealing with the results from overdoses. And she said, you just want to, and both were white in that instance, but it's the positive that comes out of all this. So, or when you hear Andrea and when you hear Todd sit here and talk and be able to put a different kind of aura around the issue that we're talking about. And Andrea hit something earlier that really bothers me a lot when I hear it, because it's a simple answer, like you said, that when people say, well, it's a choice. There may have very well been a choice the first time someone chose to use. But it's like Josh Kraft, who is an Ohio State patrolman who I've become good friends with throughout speaking and learning more about this and being on the bench. Josh said something that was really profound to me one time, and he said, I've never met a 4-year-old who woke up and said, wow, I just woke up from a nap and I had a dream and I want to grow up to be a drug addict. That's not a choice. That's something that develops, and it may be from a bad decision at some point, but the end result wasn't the choice. That's science. And some people, there are other people out there that can try it recreationally and walk away. just like any other drug. There's people that can smoke socially and not have a cigarette, for a year, or have a beer this evening and not have another drop of alcohol for 6 months until there's another event. There are people that can do that. It's fewer and far between because of the potency. But that's what scares me more than anything, not only as what I do for a living as a judge, but as a parent with 4 kids at home. When we were in high school and you went out and you made a couple bad decisions on a Friday night, you woke up with a headache the next morning. We really run the risk right now of burying our child the next morning from one night and one mistake. There's so many times that I have people coming through the court that think they've been arrested for possession sometimes, after they've passed out in their car or something like that, and they come in and they passed out because they bought heroin, only to find out they actually bought fentanyl, and they had no idea. And I know there's people in this room that can talk about personal experiences with that. So in adding to what they said, and while grabbing Michael wanted to talk, this is where the court is becoming a little different in our approach to these things. It's become evident that when I mentioned the cookie cutter approach earlier, and that's not attacking anybody that was ever on the bench before me or currently, it's how the system was. That's how the judge was looked at. We're going to bring the case, and you're going to decide the sentence after we prosecute the offender. That was the system. And the sheriff was the same. We're going to arrest the offender to start the process of the prosecution of the offender, to put the offender in prison because that's what the court's job was. Nowhere through any of that did anybody identify root cause of the problem. And that's where the focus has got to be now. We will continue to see the same people over and over and over again whose addiction leads to the crimes that are committed that puts them in front of Jeff and in front of me, and the same thing with all the other communities. Until we identify what is at the root issue, or what is the root cause of that individual's criminogenic behavior, and why they went to substance abuse in the first place, and how do you reverse the process, are you ever going to be able to help that individual? No level of incarceration is going to help that individual until the root cause is addressed.
And I'll just build on what Judge Ballard is saying there. We have 122 people incarcerated, Lawrence County does, throughout several jails across the state of Ohio. And 95% of those are all tied to drugs in some fashion, whether they stole something in order to feed their habit or what the case may be. Now, there are people out there that need to be arrested and need to be incarcerated, but the recidivism rate that I've seen over my career, is unbelievable. It's just the same people over and over and over again, or the children of the people I used to arrest when I first started out in 1986. But so when you take someone and you lock them up in jail, or the way things had been done for many years, not just in Lawrence County but throughout the United States, they would lay there in jail till their sentence was done, and out they would go. So I was glad to see Judge Ballard come on board and start the drug court, because we have to educate these prisoners that we have in jail, and give them some hope and give them some education to where they understand that there's a better way of life, and there is treatment programs out there. So this drug court that we have going on that has started now I think we're going to see great results out of that. Instead of somebody that's laying in jail taking up space that we got to continue to pay for, they get a chance to get some help, and hopefully they can see that going back to the same environment that they had is not a great choice. Like my counterpart here said, the sad thing is we live in an area where there are, very few jobs. We're limited on what we can do. So what happens when somebody gets out of jail? They go right back to the same family, the same friends, and who in this area will hire you when the job market is so limited already? It makes it hard for someone that has been addicted to drugs to go out and get a job. Especially if they haven't shown any sign that they've seeked out treatment or that they're getting away from that. So I think that the approach that we're having now in Lawrence County and across the United States is educate and help these people get past this addiction, past this disease, so that they can be productive members of society again. Yeah, and like I said earlier, I'm in the business of arresting people and putting people in jail, but there's got to be a different approach, and that approach is coming about.
Thank you, Sheriff. Andrea, earlier you and I were talking a little bit about a myth, and this was one of the questions that a reader had asked of, how are the drugs coming into Ohio? How are they getting into the country?
There's a couple of different myths, and again, I think this is our culture. We're very quick to say it's that person, right? So the first thing that we did was went for the low-hanging fruit, and the low-hanging fruit was to say the cartels. To some degree, correct. The other is knowing that, and I think that law enforcement would agree, you will not be able to do much drug trafficking out without some agreement from the mafia, which we still do not like to talk about. But that's the other piece. There are business agreements, and we were saying, this is business. This is a business agreement between two families and the mafia as to how things get trafficked. It's a big business. And when we say that we don't understand it, I've had so many people say to me, what do you mean they give stuff away for free? I can tell you right now how many times I've walked through a mall and had free coffee, a free taste, a free sample of something. All because that business, whether it's Starbucks or McDonald's, wants to extend their product and expand their capacity. It's the same business model. So one is you've got the cartel, but you also have the mafia. The other piece is the Southeast Asian fentanyl component. Yeah, it comes from Southeast Asia, but also you have what are called clandestine labs here in the United States as well as in Ohio, where you actually have scientists who have been hired to teach, how do I make fentanyl? The difference is when you're making fentanyl in a clandestine lab, you don't have the FDA standing over to make sure you're following all of the scientific methodologies. So you might have a batch that is, quote unquote, a bad batch. Not only that, when it comes in, it's usually your local dope boy or dope girl, I'm not gender specific, who is also looking at expanding their product and their customer base. And so if that means ordering from Southeast Asia, getting it shipped in, stepping on, if you sometimes I think it's so important to understand the terms and what people are saying. I've had my own children having a conversation in front of me, and I don't know what they're talking about because there's so many hidden words. If you're going to work with the population, for those of you who are caseworkers or clinicians, know the language, know the lingo, and admit to what you don't know. That's one of the cases, is they'll step on it to make sure they can try and take maybe 1 brick to 2 bricks in order to make more money. And certainly if you're the local dope boy, you're not sitting there thinking about, I might lose my customer on this. That's not a concern, because the other side of this business model that we do know from the cartels is they actually modeled it after American business, which is the customer is always right, deliver to the customer, and if the customer says they don't want to do it anymore, okay. That's really different than the previous epidemic, which was, but you owe me money. Now it's, okay, I'll just leave you a couple of hits. Because what's the likelihood you're not going to use those couple of hits? So you have to understand the entire picture, one, the individual and the disease, the trauma that is involved. When I say trauma, trauma is not something that you get to define for another person, and it doesn't happen on your timeline. I can remember saying to my mother, like, we grew up poor. I thought I grew up poor too, because my mother did. Grew up in a 4-room apartment, sleeping in the same bed as my mother till I was 15. We lived in public housing, which most communities with public housing paint all the doors the same color, so that not only do you know you're poor, everybody in the community knows you're poor. And then we had a name that everybody knew. So what do we do with names? I'm sure the judge, the sheriff, you see a certain name coming in the courtroom, you're like, oh my God, not that family again. So there's that whole legacy that kind of goes along with it. But at some point, somebody gave me an option and an opportunity and support, and my mother was doing the best that she could. But part of what she had to admit to was what she couldn't do and ask for help. And what I'm finding with this go-around is families saying, we've tried everything, we've tried everything. Well, maybe it's not you. Maybe it's letting your child find their own family and their own sense of support to navigate their own way, and you have to give them permission to let go and leave. And that's been a really hard thing with this go-around of the epidemic. Sorry, you should.
No, I was agreeing, that's 100% correct. And better than 90% of the individuals that I work with that say we've tried everything are the biggest enablers that you've ever come across. And they won't do the one thing that they need to do, and that's shut the door. Because sometimes, and that's hard, man. Yeah, it's a parent. You know, the thought that if I ever would have to do that with my child, I mean, it's gut-wrenching just to think about, let alone to be in the position where you have to do that to your child. But that could be the only thing that saves your child. But I've talked to people before that literally with a straight face been, we were so tired of him stealing off of us, we've tried everything we could, so we went and got him an apartment and we're paying his rent. That's not the solution. To give even more free rein and cover the bills. So that's something that parents have to get used to in these situations. You can't fix all your kids' problems as much as you want to. And rock bottom is a nasty place when we're dealing with this. But until you get there, very few people are going to be ready to take the next step to get help.
You know, and that really leads into sort of what I was talking about earlier about rebuilding social systems. At some point after you go through detox and after you build, you have to go back and build that trust with your family. Now, some families are toxic, and you just have to, you know, patients, you know, individuals just have to cut ties and move on. But the other side of this is the families that are dealing with these individuals, and I can tell you a number of family members have told me when he went to detox and he come back, I thought he was better, right? This is a disease that it's a chronic disease. It lasts and it lasts and it lasts. And one of the things that we don't really accentuate enough is family therapy, right? You know, where are the groups? Where's the assistance for the families? And the families say, okay, what is it going to be like? How do we interact with this family member? What are the things that I've been doing that have been enabling? You know, how do we rebuild those trust issues? Because not only then are you helping pull the family together, but you're rebuilding that social system. And ideally, you're rebuilding it in a way that allows everybody to be healthier.
One question that comes up quite a few times, too, is it going to get worse? Is it better? Was last year better? Is this year better? What has been the, you know, sort of the 5-year run of something? Sometimes when it's in the newspaper, or it's being talked about all the time, you think, oh my God, this month must be the worst of forever. What would you guys say to that?
Things will change, right? Things will change, and every 3 to 6 months, the drugs that we see on the street are different, right? It's constantly changing. But here's the bottom line from my standpoint. If we're open about this and we start working on the base problems and we work together as a community, you know, if we cut the ties, you know, if we start ignoring the borders, whether you live in Chesapeake or you live in Proctorville or you live in Ironton, and we start working, if you're in this church or that church, it doesn't matter. If we start pulling together as a community, if we work together as a community, it'll get better. We'll figure it out. If we don't, then we won't.
A prime example to what the doctor here is saying is our attack on the pill mills there just a few years ago. You know, the country had just had enough. When we're putting van loads of people in a van here and off to Florida they go, and 24 hours they're back here with just bags and bags of pills. You know, we attacked that problem, you know, on a federal level, a local level. Everybody got together and legislators got together, and we've pretty much shut down the pill mills across this country. So we can, you know, and here we are again attacking a new problem, but the same problem at the same time. So will there be good days and bad days? And yes, but what will be the next thing? The problem is the profits are so great for drugs. So these sellers aren't going to give up this life easily, and the addictions are so great that people are going to do whatever they can to fix that need. So, you know, we as a community have to continue to, you know, come up with solutions, and you fight this battle. I had in my notes here, you know, we've been at a war on drugs forever. We win battles and we win battles. I don't know that we'll ever win the war, but saving this country from this drug addiction is vitally important, and that's why we're all here today, because we want our country to succeed, and we've got to get past it. So there'll always be another drug, and there'll always be somebody out there to sell it, but there's going to be people like us that are going to fight to keep us all safe.
I think if you look at, again, from the position that I'm in, we get data inundated. And as the doctor and I were saying, sometimes the data is not real time. What I can tell you is, here's a trend that kind of outlines part of the problem. In 2003, there were 4 people in the state who had fentanyl in their tox screening. In 2014, there were 504. We went from 4% to 20% to 46 to 47% to last year, 58% of the deaths involved fentanyl. So for anyone who is dealing with this issue with a friend or family member who's doing it for casework, there is a 58% chance you are walking into a scene where there is fentanyl. So make sure you have the proper protective gear with you. Never try and recap a needle. Never try and change the scene. Make sure you're wearing gloves, all of that. Make sure I have my Narcan with me because I can bill it against my insurance. I always have it with me. But I also saw in the trend of data this. We had 14% annual growth between each year. So the numbers did not go down. The numbers are not projected to go down next year, but the percentage of growth between years is 12%. That is a success. We, as you say, we always have a new issue. What I'll say is this: we have not solved cancer. We have not solved HIV. Because these are also diseases that are connected with the human condition. And unfortunately with this, as you've indicated, sir, there is also money to be made. And the money to be made on the flip side of it was the pharmaceutical industry, which, you know, I started off by saying we always want to blame. I can blame many things. I can blame the pharmaceutical industry, I can blame the cartel, I can blame the mafia, I can blame communities, I can blame the lack of business. I am so beyond blame, because at this point it's about inoculating. How do we protect the next generation? How do we educate them on, very similar to what you said, I think for years we used to try and protect our kids, when in truth we were not helping. The governor's program, Start Talking, the whole idea, it is not evidence-based. This is what I hear all the time. It's not evidence-based. It hasn't been tested. That's not its intent. Its intent is about awareness and education, and to start talking. Start talking to our kids about reality. The reality is I may not be able to get you that cell phone. The reality is we are having trouble as a family. The reality is pain hurts. But it doesn't mean that you can't recover. It doesn't mean that you can't make it through. So part of our need in inoculating young people is to be honest with them and to connect with them from this. Because a lot of times what I hear from families, and I'm sure you do, is they're so entitled. Really? Who taught them that? Because the same people who teach you to walk, talk, and eat teach you how to cope and teach you that this is acceptable. And if you're going to complain about your kid on a computer while you're reading a text from work, then really all you've done is modeled for that child that that's acceptable behavior. So part of that inoculation process is talk to your kids. A grandmother saying, fat meat is greasy. Know that, right? So teach your kids that. The other component is we have programs. I learned about local rule, and I'm not going to go into my political thing, but I did not know what local rule was. Local rule is every county can, if they choose, follow state edicts, but they can also say, we don't want to. And so when we came out with House Bill 367, which is a requirement to educate young people on prescription opioids, prevention education, there were some counties that said, well, if you're not giving us money, we're not doing it. And then we had other counties that were like, well, we've been doing that. How could we not do that? We provide health education. Why are you having to tell communities to do something they should? It was a range of response. So what we did, the state invested in something called the HOPE curriculum, which is Health Opioid Prevention Education. It is free. It's K through 12. There's no issue about an unfunded mandate. We have to use the resources that we have and have conversations. The biggest thing, the most effective act that we can do towards prevention is preventing the next generation, which is saying this is your brain, not this is your brain on drugs and then try and scare them, because that doesn't work. Let me, just by a show of hands, I'm being for real. How many of you went through DARE or saw the commercial and heard just say no? Now, how many of you just said no? So we need to talk about effective methods and methods that are reality-based. We should applaud those 5. We really should. But again, I think it's
did
using
Judge Ballard raise his hand, or?
Judge Ballard.
Okay, I just wanted to clear that.
So the reality is we have programs that are available that are on a child's level, but also an adult's level, because this is just, we've discovered with this epidemic that's going around, there's something called the opiate naive, the person who's never been prescribed an opioid and how they respond to it. The older generation, again, I can just talk about personal, my mother, we probably had close to $10,000 worth of medication in our house. And my mother would not take it. She also wouldn't get rid of it. You know what she said? It's mine. Because I paid for it against my copay. Like, that's what our culture is, right? So then when I explained to her the molecular structure of heroin versus Percocet, that it's pharmaceutical heroin, her first thing was, put it in the toilet. And I said, no, we're not going to put it in the drinking water. We're going to get rid of it the right way. So education is critical, and prevention is critical. But also, prevention isn't just about young people, it's about us.
I'm going to throw a little science on top of what she just said here. So she talked about, getting the kids off the cell phones and getting them to start talking. This is about what we call executive functioning, right? This is what we talk about, the ability to make positive decisions, right? This is about telling your kids, that was a poor decision, right? And teaching them step by step, this is what it looks like when you make a positive decision in your life, right? And you get benefits from that. And when you make poor decisions, there are consequences. It seems very simple, but this is an area where we have been failing as a community of parents, right? Developing that executive functioning process in your kids. Now, is it going to mean that your kids are definitely not going to ever touch a drug? No. But you give them a better chance, right? And you give them a better chance of recovery if they do go down that road, right? The ability to make a positive decision and consequences for poor decision is a very fundamental learning process that every kid has to go through, and they don't learn it sitting in front of the TV, and they don't learn it from their cell phones.
Todd and I have been saying that for a while. We're waiting for the data to come out, that there's going to be a link at some point between the onslaught of personal digital devices and the disconnect that is in the family and the community, and people becoming more isolated, and children preferring to text one another than calling one another. And I truly believe there's going to be something come out of that. But I want to talk just a moment, though, about the HOPE curriculum that Andrea mentioned. Just recently, Todd helped get a few of us together in the community, and we started this group that's been meeting twice a month now for a while. Lawrence County Recovery Coalition, and it's grown. It's getting bigger and bigger, and more people are coming to the table, and we're kind of compartmentalizing into different areas of focus. And Dean Pennington here at OU and I are on one of the subcommittees that are dealing with education. and how we need to, reach out and we need to start prevention earlier in the schools. And we talked about the HOPE curriculum and everything. But we took a meeting with all the superintendents in Lawrence County and went down to the ESC and were invited in. It was a very nice meeting, and they were all there that day, and we kind of told them what our role in this group was and how we wanted to see the schools get more involved with their education, and it really needs to be K through 12. And I said it really needs to start pre-K, but that's out of your bailiwicks. We'll start K through 12 with you all in your school system. When we got met with that response was, well, how do we implement that? And it kind of turned into a conversation, and they recognize the need, they want to be involved. All the superintendents, every one of the superintendents answered a questionnaire saying that we would welcome this in the school. We believe there is a need for it to start this education. But the problem we face in defining the curriculum, you can do all that, but unless you figure out a way to put it on a standardized test, the teachers won't teach to it. Because all the time that the teachers spend now in the classes are geared toward, can the kids pass the test?
And the hardest part of that is local rule. That's where the local rule issue becomes the biggest, because when we actually developed the law that said they had to do it, I'm naive. I had been a social worker, like boots on the ground, for 20 years, but I was so excited because we did some really good work. And then when I was told, you can't make them do it. And I was like, yeah, no, it's a law. It's a law, it's on the books, they have to do it. No, they don't. So while you're correct, most teach to the standardized test. What I also know is that teachers have to score a lot of tests, and if they can have 20 minutes or an hour to have a special person come in and do the prevention education that frees them up for an hour and it's free, then they'll do it. Part of our Cures Act funding that came down from the federal government goes to the local alcohol, drug, and mental health board, which then goes to the local treatment and prevention providers to cover their cost for going into schools. And it doesn't, we were so aware after it, we got that response, we were so aware that, like, wow, it doesn't have to be an hour, it doesn't have to be 16 sessions. It really just has to hit the age group at a level they're gonna understand. And that still, by the way, is the law. You do not have to use the HOPE curriculum. You don't have to use the PACS curriculum. You could take this conversation filmed and share it to a class, an upper class, 15 or older is what I would do. But you're right. We have to make sure they have it and they stick to it. I will also tell you this, because I read faces, right? Like, that's part of being a clinician. You have to read your audience. And I can see some response of, like, we've been dealing with this for years and most families are okay, right? Like, you can see the, like, I mean, and it's totally cool because I've dealt with it in my own family. One of the things that I've come to learn is that through prevention education, you're right, the rate of substance use and the disease of addiction has never gone over 11% in the United States. Has not gone over 11%. But what if we didn't have prevention education? What would that number then go to? So you can't say, correlation is causation or causation is correlation, but the reality is, yes, there are a lot of people who've gone through a lot of stuff and a lot of families who've gone through a lot of stuff and they still come out on top. But what we're seeing in the work that we do are those families who don't. And perhaps they didn't have the support or the prevention education that they needed.
Well, when we talk about, local programs versus state programs, and this is I'm going to soapbox a little bit, I'm sorry about that. But yeah, the substance use disorder or opioid use disorder has never gone over 11%. But I can tell you, because I've seen all of the data, 20% of the babies born at Cabell Huntington Hospital are prenatally exposed, right? So as a local sort of economically challenged area, it's more concentrated here. You're not going to see it in, when you have an entire country and you have a lot of areas. Substance use disorder, as this epidemic has grown, it has really hit rural areas much harder than urban areas, because the lack of connection. It's further to get to people. It's we rely more on our communities, and as that has started to break apart, that thing that made smaller towns and rural areas stronger has started to break down, and that has actually made us more susceptible, more vulnerable to addiction. But, you know, the state doesn't know what it's like in Lawrence County. Why would they? They don't live here. Really, it is our responsibility as residents, as each individual's in here, to collectively tell Columbus, look, this is what we need here, right? We don't need you telling us what we need. We need to tell them. We need to say, look, if you want to help support us, this is what we need, and this is how we need to do it. And we need to do it in an educated way. And I'm sorry, I do advocate for best practices, whatever we're doing. But that's, you know, everybody in here, everybody in this county has a voice. Everybody can do something. And the more we do something in the same direction, the more we're going to get a response that we want. The more resources that'll come here, the more positive results we're going to get. This is not about waiting for Columbus or waiting for DC to come and help us, right? We help ourselves, and then we tell them what we need. And that is the best way to get resources here. That's the best way to defeat this epidemic here locally.
How many people have heard of the Lawrence County Recovery Coalition in the room? Just raise your hand. Okay, that's good. That's more than I thought it was going to be. Todd, do you want to just touch base on what the coalition does and how it quickly got started?
Well, the coalition, it builds on that same idea. And basically, we got a handful of people together, and we just started meeting. And it was just, hey, let's start meeting and talking about this stuff, right? And we got together, a group, and we started meeting and say, okay, what do we need? And it's providers, and it's Judge Ballard, and it's Dr. Pennington, and it's a lot of the providers. I know, Bob Vincent, you were part of getting it started, and Liz Cremines over here in NECO, and I'm going to forget everybody else because I'm terrible with names. But it's just sort of grown and grown, and we've said, okay, invite everybody, invite whoever is interested in participating, whoever can provide insight, whoever has an area and wants to do a little bit of work, and it's grown like crazy, right? And it's just a group of people from the county that provide service in the county or involved in this issue, starting to break down the pieces one by one, and you know we're breaking the elephant down into pieces, and we're taking bite by bite.
And one of the biggest benefits of all of it so far is the kind of the mantra of the group is if it moves, we chart it. And that's that's been a problem for Lawrence County and a lot of other rural counties. We have all these issues, but no one's keeping a repository of the statistics. So when we go to Columbus or we go to Washington and say this is what we need, we have nothing to back it up, but well, at least that's how we feel, or at least that's what we think. So now with all of these people coming together, and Ohio University and Marshall University partnering together on this, we're looking at building a database that we're going to be able to stick all this information in. So you want a statistic on something in Lawrence County, we're going to be able to give it to you. So when we go seek grant funding for those types of information, once we identify the need, and then now we go look for a pay source, we can go to Columbus armed with statistics that the surrounding counties aren't going to have available to them. Now, we would share that model because we all benefit, but it's a proactive approach to the problem, having identified that we can't statistically support a lot of the positions that we see every day. And if we can't drill it down into numbers, it doesn't register on certain desks when we go to the state or the federal level.
We've dealt with that, and I'd love to hear from the sheriff because I know you probably have an idea of how many runs you do on average for overdose and what have you, and naloxone dispense. But we actually, usually I have a map and I'll show, and hi Sue, there's a map that's up that shows like what it looked like in 2001 and then 2014, and then we do the crude death rates from 2016. And there are 4 counties on that map consistently that you would think there's not a problem. And so I found out, like when I read our map legend, it says, you know, this is data that is to be submitted by the Sheriff's Department Department of Public Safety, as well as the EMTs, emergency management. They weren't submitting. And so when it came time to start allocating money using data, if we don't have data, you don't have a problem. And it's hard to justify investing money where there isn't a problem. Now, we did know, and we did allocate based on first, second, and third areas, and I think the southern region of the state was strongly supported, but data is critical for telling the story. Yes, the human side is really important, but that data, unfortunately, there are people who, as you say, whether it's Washington or the state, those are like accountants. They just need to see numbers.
Josh, I left some of my notes at home. I know that we had 21 fatality overdoses in 2017, and I think that the number of overdoses was like 127. You don't have that by chance, do you? Okay. And so far this year we've had 55 overdoses, and 6 of those have been fatal. Now again, the data rolls in all the time, and what we've done here, we have a quick response team, and Josh is the director of that. Prosecuting Attorney Brigham Anderson was able to obtain some funding from the Attorney General's office, and we have dedicated, the sheriff has dedicated 1 detective to this program, and with Josh there. So when we get an overdose call, in all hours of the day and night, my detective and most of the time a representative from the prosecutor's office will go to the scene there, and they'll begin to assess the situation, and then, if able, they'll follow up with them over the next several days when they're in court, but get them into a treatment program. Now, of course, somebody has to want to do this, but they certainly want to do these things rather than go to jail, and certainly rather than die. So we've been very fortunate to put this quick response team together that goes out and assesses people that have overdosed. And again, they don't just give up on them after a day or two. They continue to follow up with them for the next several weeks. In fact, they have an option of having any kind of their drug abuse charge reduced or eliminated as long as they stick to a program and follow the criteria there. So getting that funding from the state and being able to put this team together was great. And we kind of modeled it off of the Hamilton County Quick Response Team. They've been doing it for the last couple of years, and it's worked out very well. So just another avenue for us to continue to help the public. And by helping these people addicted to drug, it helps all of us. I don't want somebody behind the wheel of a car that's drinking, and I certainly don't want somebody behind the wheel of a car that's been, taking some kind of drug. So, the drug addict's problem is not just that person's problem; it's all of our problems. We all have to be concerned.
The QRT officer's role the other day. We were having a conversation on the steps in the courthouse on Monday, and we increased his role. We found out that same day, and going back to the statistics, when the EMS makes a run in Lawrence County and naloxone is administered, they chart the dosage. But they do not chart if anybody administered naloxone before EMS arrived. Yeah, and it's a procedural thing. They chart what they have done on scene. But with our QRT officer going to the scene, or at least visit with each individual who has OD'd in the county as required by the role, that is something that he is going to pick up and start charting. So another piece of data, and he's an avid member of the Recovery Coalition. He doesn't miss a meeting. But so there is just an opportunity where he's saying, yeah, I'm already doing it anyways. I'll pick up that information. He can cross-check it with the number of doses that were issued by Lawrence County EMS or any other of the EMTs that respond. And then we will have at least a spot where we can look at and say, these were the total number of naloxone doses administered during investigated overdoses in the county.
We now have him going out in real time. Like he gets a call out in the middle of the night, he tries to get on the scene.
Yeah, and I was going to jump into what Judge Ballard was saying. this shows how well, we're all working together. And for the EMS to be on board the way they are as well, and they provide us the stats. Now, again, there are some HIPAA laws, but there are some rules to that as well. But we need those people's names. We need that information. And just like she said here is, Columbus wants to see these stats. They want to see these numbers. They want to see that you're doing something with that money, and we can certainly show that so that we continue to get funded. So we're working hard at having some of Columbus's money, or which is our money, come back down to us so that we can use it and try to make things better. But there's a lot of work on this thing that goes on behind the scenes that the public don't see. But when we have a very active judge here that's right on board and pushing, which is great. We have the EMS that's right on board with us, and they're always working well with us. Not only the sheriff's office, but the other law enforcement agencies throughout our county are all working together. We've got a drug and major crimes task force that works very hard at making arrests and helping rid our county of drugs. We average, for the drug major crimes task force, we average 70 major arrests a year, and the drug task force has a 100% conviction rate. Now, I get complaints from time to time. Johnny down the street's selling drugs, and he's been doing it for the last 6 months or a year, and you guys aren't doing anything. Well, that's not true in 99.9% of the cases. We are doing something, but it takes, in order to follow what the law says, and in order to build a case that will put this person in prison or to help get, stop this thing, it takes a long time. You're talking at very minimum 6 months to build a real good case on somebody. But to have a 100% conviction rate year after year after year shows that we're doing something right. I was trying to see if I had the...
Can I interject? Can we introduce Josh? Do you want to stand and just so that we know who he is, because he's been answering some things. And Josh's last name and title? Josh Whaley, and his title? Okay.
Case manager for Judge Ballard, Texas Recovery Docket, and I also help Judge Waldo with his newest one.
Okay, that is a long title. That's
can
fantastic. Go ahead.
Really telling.
But I'm the only one that pays.
I'm trying to.
I'm his favorite.
This is one of those, this is the perfect example of how over time a community and a culture can change, right? The fact that a judge is providing a therapeutic problem-solving court is unprecedented. The fact that law enforcement is helping is amazing. I will tell you, when you said that about the doses, the reason I did my shake thing is just the other day I got a call from a county. The governor allocated $750,000 to go to first responders being primarily law enforcement because EMTs have always carried naloxone, but law enforcement had not. So the thing was we'll give it to you, right? So it goes through the health department to the first responders. And this community called and they were like, we're out. And I was like, okay, no problem. Just send us your data so that we know how many doses you dispensed and map it so we know which are your hot zones and we have an emergency amount, we'll give you more. And they were like, we didn't keep the data. I had an earful. We're gonna give them the emergency dose, but the other reason we talk about it from this perspective is this. I don't know who's getting elected next year. I don't know that there's a guarantee that naloxone will be given to first responders from the state. So you have to have data that also goes to your county commissioners that says, here's how many lives we were saved, this is how much it would have costed us in indigent funds, in emergency hospital, therefore it may cost us $10,000 to buy the stuff for the sheriff's department, but it's worth the investment on the other side. So that data, it's another example of why it's critical. I'll also tell you that peer recovery supports for the quick response teams is essential. How many folk in here have sobriety of over 2 years. These are the very people I would be going to say, I need you to be a part.
Yeah, that needs an applause.
I need you to be a part of our quick response team, because law enforcement's going to go to secure the scene and make sure everyone's safe and try and help. And you're going to have the case manager there who's trying to get them linked to treatment. But sometimes, and we can say this from our own experience, that person who's walked that walk can say, I know this is scary. I know it is, but I'm here with you. And I will say this, that person is trained. It is not just I've got 2 years. They go through a training and they get certified in order to be able to do it. So hopefully, now that you saw them, Josh, you'll be reaching out to them.
I want to real quick, Scott, on the Narcan. We've been carrying Narcan, I think, for 3 years or so, and we, the sheriff's office, have never had to purchase any. We have been very fortunate to have the Narcan donated or given to us. When it first started out, the head of the drug task force, Dave Markham, and I, started reaching out to hospitals and King's Daughters was very, very kind, and they purchased a lot of Narcan and supplied the sheriff's office that, and even resupplied us a time. Since that time, the governor's office and the attorney general have been able to provide some funds, and again, like she said, it goes through the health department. And when I call up and say I need more Narcan or this many more, and she's, Debbie Fisher, who is running the program, or at least the one that I deal with, and she happens to be my sister-in-law, but she demands that I give her the stats before I get resupplied with Narcan. And so it doesn't matter that I'm related to her or that I'm the sheriff or anything else, because she has to report those stats back to Columbus, back up north. So now, that is important because my budget and everybody's budget in this county is really tight. So without the help of somebody providing Narcan to us, I'm not so sure that we'd be able to continue to support it long term. So I'm grateful to what King's Daughters has done for us, and what these other entities, the governor's office and the attorney general's office do, and the health department oversees that thing. So, but I want to throw that out.
And one other, I know we want to get to questions, but I have to say this because, Andrea, it meant a lot what you said, and I appreciate the recognition. But the name that's not been set up here tonight, and I want to make sure is mentioned, is our prosecutor, and Brigham Anderson. Brigham was fighting this fight by himself for a long time with little support, and his diversion program was in place, and Brigham was begging for someone to come in and do what we were able to do, because he was prevented from touching the drug crimes directly. The way the law is written in Ohio, the diversion program is limited to people who do not have a drug offense, certain felony levels that don't have a drug offense, because it's encouragement for the courts to start the drug court, and that provides a therapeutic approach. So Brigham really had his hands tied, but he was looking for something to happen. So, and I always give him credit when we get in and talk about these things. I mean, he's a great friend of mine, but also I respect the world out of him, because he didn't care to stand on an island. And, and if we couldn't be talking about, that's one of the things too. I mean, the cooperation is phenomenal with what we have. Jeff knows my door is always open. Jeff comes over and sees me. I've got no problem picking up the phone and calling him on the weekend. We consult all the time about things like that. Brigham's the same way. I will pop in his office and just sit down and we'll talk about what's going on, within the community. We have limitations that we can talk about under professional obligations and rules. We can't discuss cases that are pending and things of that nature, but that's such a small point of what we do on a daily basis and what we have to talk about. Having Josh there was a beautiful thing, because Josh was already there from day one on the diversion program and stepped right into the drug court case manager docket. So now if it's a felony level diversion or drug court case, he's the repository for all the information. You can go to Josh, and he's going to have all the numbers for everything on both Brigham's side, where I never see those cases, and on my side, because once you're in the drug court, basically the prosecutor and the defense attorney step out of the picture, and it's just the judge and the court and the treatment team at that point. So we know we're controlling the data, and we can be able to come and look at it. But I just wanted to take a moment and mention Brigham, and I know the sheriff feels the exact same way about him, and he needs recognition tonight for his part in all of this fight as well.
How many, wow, I apologize. How many people know that we have a drug court in Lawrence County? Raise hands. That's great. Did you want to touch base on a little bit of just what it is? And before he starts, too, I have one thing just for time. How many questions do we have? Raise your hand if you have some questions that you're going to ask. Okay.
There we go.
It can be more. I'm just asking because we're going to do that next. So,
What's that?
what's that?
Deacon, you want to go ahead? All right. I'd give you the floor. So, all right. Better yet than talk about it, come down and see it. It's open court. It's open to the public. It's the first and third Thursdays of the month. The treatment team meets in private ahead of time. We try to get the docket rolling at about 1:30. It's something to come witness, because I didn't know what it was going to be either the first time I ever went to one. And it's, you know, having spent the last almost 20 years in a courtroom, courtrooms are familiar. I know what goes on in a courtroom. I know procedure. I know which table to sit at depending upon who I'm representing in the room. Drug courts are not that way. Drug courts are something that you really, I can talk to you forever about it and tell you the details, and it doesn't do it justice until you come down and actually see it firsthand. Basically, just, you know, the small snippet of it. A drug court, for those of you who don't know, it is literally defined in the rules of superintendents as a specialized docket that has a therapeutic approach to justice. So it's me and a treatment team that I put together that sit down and look at each individual who gains admission into the court on a case-by-case basis and tries to attack that root cause that we were talking about earlier. It's made a difference already in one individual's life. Just a short little snippet from our Recovery Coalition meeting last week. I spoke about a young lady who was about a week into sobriety. She got into the court. I put her into the court before she was even arraigned or pled guilty to the charges. She came and did the court the following Wednesday. I put her in ILC, so, you know, we're waiting for her to do her treatment time and finish the court, and she'll have the felony dismissed off of her record. And the supplier was a coworker. Well, what she was doing outside of treatment and trying to stay clean because she was in trouble, she was working 10 and 12 hours a day, which we thought, well, that's probably not good, but at least you're working. The following week, reading the court file, we read, well, the person selling her meth was her coworker that she's working 10 and 12 hours a day with now. And I mentioned this at the recovery meeting, and Liz was standing there, and we have an individual come up afterwards and said, well, she doesn't have a felony conviction, does she? And I said, no, I mean, she's under ILC, so as long as she doesn't violate the terms of ILC and we institute a guilty plea, it's not technically a felony conviction. And they're like, we'll hire her. We'll be at court Thursday, and we'll offer her a job, and that'll get her out of Burger King. Yeah, one meeting.
Well, it's actually not a question, but I'd like to respond to and thank all of you all for your impact. It's bringing information to our area. But I'll stand here to say that possibly I'm one of the elderest people in this room tonight. I'm 70 years old. But I say that, I hear the information given, but we have an organization here, the Impact Prevention, directed by Molly Stevens. And we're kind of targeting the different schools in the Lawrence County area. Ironton, Cold Grove, South Point, and I think it's Rock Hill. And the conversation came up is how many children are involved with alcohol abuse. In our area, in Lawrence County, it's 30%. And that's in Lawrence County. There's 88 counties in the state. How can Lawrence County project 30%? And you talk about how come we have an opioid situation? And we're talking about elementary and middle school. I didn't say high school or university. My wife is a school nurse over in Ironton. maybe some of you all know her. She comes home crying constantly of what's happening in the area. But are we heard? I just heard a few moments ago talking about the state involved in sending different petitions and getting money. Next Tuesday is the primary, right? But how come we're being addressed right down here now, a week before the primary? On our TVs in this area, I hear everything that's happening in West Virginia. I don't know a lot of my legislators in the state, but if they were publicized down here more, like what you're all doing, I'm not badgering this evening, but if we would be able to reach out, because they work for us. The state works for us. And I think that you're here because they have always made mention in our area and in the state of Ohio, and the United States said, so goes Ohio, goes the election. Well, how come we can't get something to project right here on this river? Something's wrong. From a moral standpoint, I'm not ashamed who I am or what I project. We need to integrate God in a lot of our informations to get things started. But we've got to step out on faith and get things done. Because, I'm tired of people looking at me before they listen to me. I hope people understand what I'm saying. Because this stigma has been stuck on me for so many years that who I am before what I am. As I told Judge Ballard many weeks before, you could have been me. Very easy. So why don't you listen to me when I do respond to you? People look at me, I walk into Kroger's, they say, and women, they'll jump back. And I stop one day, and I thought I was presenting myself pretty well. I said, I'm not your enemy, honey. Not me. But we talk about the opioid situation. We talk about drugs. But I was in Chicago to tell you a story. I have to go. But on 67th and Halston in Chicago, in 77, there was $1 million a day drugs going off the corner. People say, it can happen. $1 million a day. Now people look and said, well, how did these drugs get here? I just heard it a few moments ago. Well, my pants are not baggy, my hair's not bunched up, but I'm not the enemy. But they said, we got to stop drugs coming in from Detroit. But every time they say Detroit, who do they look at? But I don't bring them in. I don't have that type of currency. I don't have that type of power. But what kind of power I do have, that hopefully we can get information like this, and somebody knock on the door up there, because I am somebody. I really am. And I thank you all for this time, but there's so much I would like to say, but we won't get started until we come together, because you don't see too many of me in this room tonight. Where are we at? And the other day it hurt me so bad. It was in the elementary schools, and they said, well, where are the black children? Where are the black children? I said, there they are. No, where's the black children? I said, there they are, right there. But they say, oh, well, his mother's white, or his dad's black. There's the children. They're there. But see, the stigma has stuck on people, a person, so long that I'm not the problem. But we will get there. If we don't, we'll perish together. The good Lord's trying to tell us something, you all. He's really trying to tell us something. And I'm not here to preach to you, but I feel pretty good. I feel pretty good. But well, I got to thank you for it, but I hope I'm getting my point across that 30%, I just had an interview, the young lady that sent a report to Columbus to hope we can get a grant. 30% of children in the elementary and the middle school on alcohol. Now, where did the drugs start? Thank you.
Thank you so, so very much for several reasons. The first is, do know that alcohol is still the #1 reason that people are going into treatment. It is also the #1 cause behind accidents. Thank you. We do consider this, and what I started with when I said a disease, chronic, progressive, that can lead to illness. So you may not start with dope, but you may end up there. You may start with alcohol, taking some from here and there when you're at home. But it also goes back to the root condition. If you're growing up in an environment where that is considered acceptable behavior, where it's considered, I've had a hard day at work, the first thing I do after a hard day is drink, then you're modeling for me that hard means drink. So a lot of it is relearning, because again, we do have this generational difference of, but that's how I grew up and I'm fine. Are you? Because if your other generations aren't fine, I don't know that you are. And the issue of race is this, and I talk about it openly because I say all the time, I am transparent. I don't whisper. We are so busy trying to find the Mexican or the brown person who's dealing that we're not recognizing that this goes beyond race, and sometimes it's the most obvious person who is dealing. I actually had an elderly person who was arrested, and when I was running the drug court, he was a runner to Detroit for a young guy who was white, because what he could do is, I'll pay you $500 to drive up, I'll buy you lunch, I'll pay your gas, I'll pay you $500 more to come back. It's not just young people, and it certainly isn't just brown people. This is a problem that we all have to deal with, and sometimes that means confronting what makes us uncomfortable. But if you aren't comfortable going to the places that fear you, it will eat you alive. And so I appreciate that. But do know, with regard to the alcohol, still the #1 reason that people are going into treatment, still the #1 reason that we have accidents. I would highly suggest getting with your local alcohol, drug, and mental health board to talk to their prevention partners, to get the education, not just in the schools, because if it's not convenient there, then find the other spot where kids are. Kids aren't always up in the school. In fact, the kids that need it the most aren't likely to be sitting there listening. Find out where they are and reach them in the community. Thank you so much.
Thank you all for this. This has been great. So my name is Adrian Buckler, and I'm a local attorney in Portsmouth, Ohio, so just down the road in Scioto County. But I'm also running for state representative for the 90th District. So wearing both of those hats tonight, I would ask all of you and anyone else in the room, what would you like to see from your state legislatures to help combat this problem?
Spend some time with recovery group. Sit with them. I don't mean once. I mean the folks that are going through the recovery and they're in counseling. I mean, I have a fancy degree, but I'm telling you, that's where I learned everything. Sit with the folks, sit in the drug court, and listen, and you will learn more than you're going to anywhere else.
Ohio does not require health education. It does not require it. Reading, writing, and arithmetic, and not health education, which is at the root of everything everyone up here has said. Resiliency and protective factors are taught through health.
And I'm going to be extremely honest with you, and this is not meant to offend anybody. I've kind of built a reputation for saying what I think and, and being honest. That's where I say I'm not a politician. I was just a lawyer who was elected judge. I would like to see involvement, I guess. I think it's on there because I have really lost faith in state and federal officials. I have no faith that anybody from outside my community is going to come in and fix my community. I will take their money, and then we will try to fix it ourselves. But I don't look for Columbus to fix this problem. I don't look for our senators to fix this problem. I don't look for our congressmen to fix this problem because they're not here. And you got to be here to fix the problem because you got to know the problem. So until I see someone from a state or federal level actually show interest in Lawrence County and have boots on the ground here and try to make a difference here, as opposed to coming in for a luncheon every 3 months or sending their attaché down to be on a panel discussion who can't really speak for them, but here's the senator's business card and things like that. That's what we get a lot of. Like Andrea, she came to the very first event that we hosted in Lawrence County after I got elected, where Brigham and I put together that event up at C3 Church. And yes, she came with the governor's name attached to it, but it wasn't like, well, this is Governor Kasich's representative. This was Andrea Boxill, and now she's back. And she will come again if I call her tomorrow if I need her. I have faith in her. I don't have faith in my state or federally elected officials that are supposed to be taking an interest in Lawrence County because they're not here even feigning an interest in Lawrence County.
And that's where I was going to, and probably as blunt as the judge is money, funding, and like he said, we need to be funded for the programs we know are working, so that we can make them work or continue to make them work or advance them to make them work. Local government funding has been cut to a point where our commissioners have had to really juggle things to make it work. They've had to cut things, and then with the local government funding cut, then we have to be creative on how we make something work. So, you know, in my opinion, it comes down to funding, but don't hamstring us or tie our hands. You know, when you see a program that's working, you know, and somebody asks for funds to keep that program going when it's helping a vast majority of the community, then I think that's what you need to look at and then continue to help try to fund that.
I'm a local family physician, and one of the things I struggle with is that I'm trying to not create addicts. I get a lot of people on chronic opioids and chronic benzos, but what I find I struggle with is that people that don't have hope and they don't know how to cope, it's easier for them to want to take a happy pill so they don't have to deal with anything. And I struggle because their lack of mental health resources for them to be able to get treatment other than medications. And I would appreciate any help that would make that job easier, because we would create better communities that way.
Can I suggest one thing, and then because you're the clinician in the area. So there are two things. We received money from the CDC because when the fentanyl thing hit, we just didn't know what to do. Well, a couple of things came out of that. One was the anomalies. We do update if there is an anomaly. But the other is we had to come up with a social marketing campaign, because we have physicians like you who said, I don't want to prescribe. I'm trying everything, but I don't have resources for alternative treatment. And I also have patients who are very skilled in pill seeking. I'm happy to say through the prescription drug monitoring program, through ORS, through the state, that's decreased by 82%. We actually have seen it go down 82%. The other is we came up with a campaign called TakeChargeOhio.org. It has 3 ports of entry. One for the patient who says, I don't want your opioid, because I went to this forum and I realized that actually acetaminophen and ibuprofen are much more effective in dealing with pain. I just dropped you that little bit of knowledge. So that's one. So go to that, and it has an entry for the patient, but it also has a portal entry for you, for the prescriber to talk, how do I address this issue with my patient? What tools do I have? But then also there's a part on it that shows you treatment options, not just for addiction treatment, and it's up to date in real time. So if you go to takechargeohio.org, that's one resource. But now I'm going to get on my other soapbox, which is I hate that every resource is now connected to a computer, because it inherently makes people think that everyone has access to the internet, and they don't. So for that reason, I'm connecting you to your local alcohol, drug, and mental health board, because they can tell you who the treatment providers are. I'll also tell you through our cures funding One of the things that we're doing is recognizing that counties like this, counties like Guernsey and Vinton, don't have a lot of mental health and AOD treatment providers, so we're coming up with creative ways to incentivize them. We're not asking you to move there like a northern exposure, but if we pay off a portion of your debt, would you be willing to open practice for 2 days a week within that region? So that is in the works, and we're rolling out Cures 2.0 next week. So go to your local alcohol, drug, and mental health board because they'll have more information, but then the good doctor here can tell you other information.
I don't know, that was great information. Well, yeah, it's the Adams board, and it really is tough being a physician in this environment because I mean you're looking at, especially a family physician. I mean you're looking at you know diabetes and sniffles and broken bones and all of those things, and this is dealing with mental and behavioral health issues is really tough, and med school does not prepare you for those kind of issues. A lot of that you pick up as you go along, and really the mental health services in this area are pretty low. Our substance abuse counseling is actually fairly robust, but when you look at co-occurring conditions and other things that are often, you know, a lot of patients are self-medicating with alcohol or self-medicating with opioids, and getting that connection. One thing that from a state standpoint, I think we seriously need to look at is telepsychiatry and
Which we are.
telehealth and in the psychologic standpoint and counseling from that standpoint, because then you can spread out to some of these rural areas. It's a problem, and I'm not going to pretend I have any answers for you. But those resources that she described are very good resources. Looking at, and the literature is pretty clear, acetaminophen and ibuprofen are far better pain relievers than opioids are for the majority of issues. Now there are some things, right? There are some things that you have to think about. But one thing, if you're looking at a patient, and you're thinking, okay, this patient really does need an opioid. The thing you want to think about is, okay, if I'm prescribing, what is my deprescribing strategy? Right? How long is this patient going to be here? What's the progression of this particular patient? And as you think about that, I think you'll find you'll probably come up with other strategies and look at ways of helping the individual patient. It's going to take more of your time individually spent with each patient, but I think as a family physician, you probably are used to that.
Well, one of the things you talk about is time, which
you don't have.
No problem. When oftentimes when I can be running because I take time an hour and a half behind, but that's part of the way that the medical system is set up in today's world. But we're talking about resources. I can give the patient, oh, do this, do this, do this, but I don't know, and you probably are aware that people that living in this town, first of all, I have a lot of patients that don't read. I have a lot of patients that don't drive and don't have transportation, and they don't even have the money to get a cab. And they have to pay somebody $30 just to take them to the store so that they can get their groceries, which is about sometimes like half their food stamps.
Right, and Medicaid will pay for transport, but there's no transport companies around here to take Medicaid's money.
So I can go through all these resources, but if the patient doesn't have the ability to take advantage of it, and that's the frustration, that I can give them these resources, because if you look at pain management, it's talking about psychotherapy, it's talking about massage, it's doing about that. Medicaid only pays so much, and it doesn't cover all this other stuff.
So just to make you aware, because I don't want you, so the other thing, I actually said to the doctor, I'm surprised every day I walk in and have a job because I'm telling them the same thing you're saying. So one of my issues is I know that the Department of Transportation, the Federal Department of Transportation, allocates 70% of the budget to the state. 70% of the state's DOT budget is from the DOT. Of that, it is required to provide public transportation in every county. Do you have public transportation in your county? Speak to the folk who are your elected officials on getting your Department of Transportation money that's dedicated to public transportation, which could also potentially cover transporting individuals, right? But then in addition to that, we have been working on the telepsychiatry because we already do it in our state hospitals. So what we're trying to do is to get Medicaid to cover the cost. So we've just finished the redesign of Medicaid. One of the issues that has come up is when you start adding all of these prescribing protocols, then you have to give an alternative for treatment, and we need Medicaid as well as the HMOs to agree to cover the cost of treatment. These are meetings that are ongoing. I think you probably know, just like if you deal with the pharmaceutical industry, the lobbying industry for the insurance industry is strong. But your voice, your examples, and putting all of these folk on a bus and showing up for a hearing has a huge impact. It puts a face, it puts a name. I don't have answers for you other than I'm trying and we're doing it. But at the end of the day, it is continuing to write to your representatives to show up at their desk, to go to when they have those open days, and then also, if they're not doing what you need them to do to represent your community, you have an option. I can only go that far with that statement.
Yes, I'm Timothy Perkins, and this is, I'm not a very good talker, but Judge Ballard, I really have a lot of respect for you, and you know, talk about kids and everything. I'm 58 years old, and I've had to sit in front of Judge Ballard here about 3 times in the last month or 2, and he has given me chance after chance, and I really do, you know, thank you for that. And I got a brother-in-law as a sheriff for Jeff Lawless. I got 2 kids as nurses. It's King's daughters, school teacher in Ironton, school teacher in South Point. So, I mean, I've done good, and I'm 58 years old, and I really appreciate you.
Hi, I'm Angela. I'm actually one of your Lawrence County recovering addicts residents. I've been sober for almost 7 years now. And the only reason I'm sober is because Bollinger and Markham done their job correctly. So I want to thank Lawless for that. My question is, I'm grateful for the drug court docket that you're doing. But are we not trying to revamp the children's services and the probation department? Because we've got people in prisons that's coming out that's got nothing to offer to them. When I got out, I was on probation for 4 years, but I wasn't required to go to self-help groups. I wasn't required to do all of these things. Why are we not implementing all these things that we have to offer to these people?
As you can probably imagine, there are a lot of different parts. So a couple things here to talk about. One, again, to kind of promote the coalition that we started. That has been a room where DJFS has sat down now and been able to field a lot of these questions that community members have. That's an independent governmental agency that we have zero control over, either through the court or through the probation department. We have looked into some partnering agreements. I had agreed a while ago on Rich Blankenship, the assistant director down there, was getting a grant that was going to allow them to provide classes, parenting classes for persons in recovery that were trying to get their family back together. Well, it fell apart when they figured out it was a matching grant. So you had to put up an equal amount of funds to get the funds delivered, and they couldn't do it. But I had already promised, saying that because it was based on them needing so many people in the program to continue the funding. And I had already pledged that any person, any felony offender on my docket, whether they were drug court or not, that had children that were on probation, I would make it a term and condition of their probation to attend the parenting classes at DJFS. So there was a cooperation there, but they ended up not going forward with it. Now, NECO has involvement with that Liz could comment on. But that's, and I understand the confusion because we see it all the time, and it's good to have these conversations in public. You think government, so especially local government, everybody's there together. My jurisdiction is countywide, and what I do is in the courtroom. And that's really, unless it's in front of me in the courtroom, or it falls with something that someone brings voluntarily on the civil docket, or that is brought to me through prosecution, I can't do anything about it. Sheriff Lawless made that comment earlier about people calling, and I get those same calls and saying, someone's selling drugs down the street. And I'm like, great, call Jeff. And then Jeff is apparently telling him, I'm sorry. That's what we figured. But I mean, we want it to be a solution, and that's the good thing about it is, the positive is, I think there's more going on right now between independent government offices that are in our county and local agencies than I can ever remember. And so there's always a silver lining too. There's some good coming out of the tragedy of this epidemic. We are learning to cooperate, multiple offices, and that is a great concern that you have brought up, and it's something that is being looked into. And there's a lot of problems, and we're even looking past that to additional problems down the road. We were talking the night before everybody got here, you know, how many in this room know somebody that's raising a grandchild right now? Okay, there you go. That's what we see across the county. Now, what are they going to do if that child becomes addicted and they have children? We're on the verge of losing a generation of grandparents. And we're talking about my kids. When my kids have kids, it's my contemporaries that are right in the middle of the bulk of the addiction crisis. And there's not going to be grandparents to raise those kids. So Liz, what are you going to do when we have, look at the problems we're facing now with placement, both through NECO, DJFS, other agencies in the county. What are we going to do 25 years from now? We can't place all the kids now. So it is right. You are absolutely spot on, and it's a hot topic, and it is being addressed, probably not as much as it needs to, but it's on the list. And we're looking long term on that as well.
Thank you so much. This has been really enlightening. My name is Joan Fearing. I'm also running for State Representative District 90. I'm Ms. Buckler's opponent in the primary. My great-great-grandfather settled at Hanging Rock and worked in one of the furnaces. So I've had family in this region for 4 generations, I'm sorry. And my aunt and uncle had a farm in Ironton, John and Elsie Fearing. She was a Lambert. A lot of people know the name. She was actually Don Lambert's sister. So Ironton was always my home away from home growing up and as an adult until my aunt and uncle died and they sold the farm. But so this is a very important area for me, and this is a very important topic for me. And I was glad to hear somebody finally mention self-help groups, because that was one thing I hadn't heard, the 12-step programs. My dad was in AA and died with 28 years sober. So I have a lot of familiarity with the 12-step programs and the importance of that for community, for accountability. And drugs have also impacted our family too. One of my cousins has lost 2 of his sons. So it's a really difficult issue, and one very dear to my heart. And the thing about the grandparents raising their grandkids, that's a big problem in Scioto County too. It's across the whole region. And you know, Ohio gets less money, less funding for children's services than any other state in the nation. And even if you double it, it's less. And they want the counties to make up that difference, which I think is we can't, you know, we're all strapped. These counties that are fighting these problems, we don't have that kind of funding. So these are the issues that I hope to work on if I get elected. And even, you know, one of the things that I talked to Lisa Roberts about, who's, you're nodding, you know her, from the health department in Scioto County, is the highly heredity factor, the high heredity factor for addiction. We know this with alcoholism. We see it with drugs. And this area is so isolated, and we're all related. You know, we're all like, it's a lot more, it's a lot less than 6 degrees of separation. It's like 1.5 or something. You know, we all know each other, we all know our families, we're all related. And I was talking to her about a possible study of this area in that regard. You know, why is our addiction rate so much higher? Why are 30% of the kids on alcohol when I think the average is like 10 to 15? You know, why do we have such higher rates of addiction? So these are all issues.
Do you have a question?
I'm sorry.
That's okay. We're not here to listen to politicians.
I'm sorry.
We're here to try to solve a problem.
Yeah, you're absolutely right. Naloxone, or you talked about naloxone, but what about Suboxone and vitriol for prevention and healing?
Well, okay, so now naloxone comes down to economics, really. You know, you can make, I know a lot of people have made a moral argument that maybe naloxone isn't the way to go. But the fact is, when you look at the overall price of this, cost of the system, naloxone is what, $40 a dose? $40 a dose. And the cost to Medicaid, if a patient is administered naloxone in the field, is about $7,000 less once they hit the ER. So the cost differential in terms of a public health crisis isn't even close. So from an economic standpoint, you know, Narcan is an easy argument to make. When you talk about Suboxone, I talked earlier about medication assisted, right? So we have methadone, right? And methadone is an opioid replacement. It's a short acting agonist, which means it activates the opioid receptor. And the idea is you get people in that dopamine range. You keep the withdrawal away so that they can respond to cognitive behavioral therapy. The methadone, the Suboxone is not the therapy. It's the bridge to therapy, right? And so if they're not getting really functional cognitive behavioral therapy, then giving them the drug is just a Band-Aid, right? And not a very effective one. The reason we use Suboxone, it's buprenorphine. Suboxone is actually buprenorphine and naloxone together. If we use pregnant women in MAT, we use just buprenorphine. Buprenorphine is a partial agonist, partial antagonist, right? So what that means is it's very hard to overdose on Subutex or Suboxone, right? And there's a little bit of naloxone in it, so there's a ceiling effect, right? So no matter how much you take, you really have to take an enormous amount to get into any kind of danger area, and that's why we use that in terms of medication assisted. The Vivitrol is an antagonist, right? And so if you get sick so the opioids don't work because it's blocking the receptor as an antagonist. Some physicians like it, others don't. It all depends on the individual. For some folks in recovery, complete abstinence is the right way to go. For some, it's the buprenorphine is the right way to go, and some Vivitrol is the right way to go. It really depends on the individual, what their therapist thinks and what their physician thinks.
As well, and if I may, in terms of cost, so the methadone is about $2.08. The Suboxone is about $8, and it must be administered with the recommended protocol. We have looked in, so what we do with the Governor's Cabinet Opiate Action Team, aside from me every month, is we really look at data and analyze, and we also look at prescribing practices, and then look to see if that physician needs to be investigated further. I had to say it the right way. So if you have a physician who is charging a Medicaid patient cash dollar for visit, and is prescribing 16 to 32 milligrams of Suboxone, that's a red flag to the Board of Pharmacy, and it's a red flag to the State Medical Board, because the recommended dose is 8 to 12 milligrams. Because again, it's not to act as a methadone, which is to replace. So you'll hear people say this a lot, it's a drug for a drug. And I go like this, nope, it's a medication for a drug, which is highly monitored by the FDA and the DEA. It is to supplant that desire to use, so it does sit on that receptor, but it's not to get high. And if you see a friend or relative or peer who is dosing as if they are, then that tells me their dose is too high. The purpose is to make sure they function, to make sure that they can maintain their job, maintain their family, not have a child in placement. The other is when you use Suboxone, as he said, there's a ceiling effect. However, if you have a person who is opiate naive, typically a young person, there have been cases, they are rare, of overdose and death. Vivitrol is about $1,200 per shot, but can be billed against Medicaid. My biggest concern, as he already said, is when people think it's this one thing, I'll just give you this and you should be fine. No, because if you never get to the very quick of what got me to this point, whether you take my desire away or whether you only give me a little bit of it or a ceiling effect, it doesn't matter. I still have a wound that's in here. So counseling, individual family group counseling is critical and should be required of anyone, and I'm sure, of anyone participating. And also we do look, the new prescribing change is also that if you're prescribing an MAT, they will be looking at your records to make sure that counseling is provided, if not provided by your office, that the person is referred to it. But I will tell you this, you have a lot of folk in the recovery rooms who do not agree with medication-assisted treatment. And my only response to that is this. If we're talking about a diabetic who's taking diabetes medication, Januvia, we don't have an issue. And we would never say to that person, any of you in here have high blood pressure? Stop taking your medication in 2 years, because if you're not well by then, it tells me you didn't do what you needed to do. But we do that to the disease of addiction. We say you get 2 years. You get only this dose. If we want to call it a disease, then you have to be able to treat it as you would any other disease, which is an indeterminate amount of time of medication, as well as what the treatment is going to look like. And for those who say, but we shouldn't have to go to AA, we can't court mandate an AA because that's considered fellowship, not treatment. But I can tell you from the many people who've gone through it, it is their saving grace because they're with like-minded people. So I can't court order you to do it, but what I can court order you to do is go once or twice to see how you respond to it. And more often than not, they come back and go, I was with people who understood me, with people who got me.
Well, and just to follow up on that, any kind of therapy you're in, there's been a lot of studies done. If you're supplementing that with peer recovery, you're far more likely to be successful.
Hello, my name is Bonnie Holmes from Ironton, and I'm the mother of a 40-year-old son who is suffering from an addiction the last 20 years. And my question tonight, I have one for Chief Lawless, and I want to commend our judge on finally getting a drug court here. I remember that was your statement when you ran for office, that you were going to get it here, and I appreciate it. But another statement you said that I thought is going to be really good is that you're going to look at the family dynamics. It's not just the addict, but the addict and the family. To Mr. Lawless, I remember Dr. Canos served as the medical doctor for the patients in jail or the clients in jail, and he's no longer, he retired. Is it true that now that it's supplied by medical physicians from Columbus, Ohio State?
You mean the jail doctor? Is
Yes.
it the jail doctor? She actually resides in Jackson, Ohio, Jackson County, and most of the staff. It's Premier Health is who it is. We've contracted with Premier Health, so but our doctor is in Jackson, Ohio.
Okay. Well, also, what I want to ask is, you're worried about getting data for that concerns how many addicts and in the relationship to the overdoses. But do you collect any data on those that come in with psychiatric problems or psychosis that develops after so many visits? Do you see them over and over and over again, and the effects of alcohol and the drug has affected the brain?
When we book somebody into jail, there is a panel of questions that are asked of that prisoner, which will indicate, if they're being honest and truthful, which will indicate what kind of problems and issues they have. And then after a period of time, within 14 days, then the medical staff gives a 14-day evaluation on that person, and they talk one-on-one with either a nurse or a doctor.
Okay. So if that patient needs psychiatric drugs, how are they supplied to the prisoner while he's in jail?
Now, and we'll refer back to Dr. Kanos real quick since you brought him up. He had a pretty hard line on what he would prescribe to an inmate and what he would not allow into that jail. So the Premier Health, the way they handle it is quite different. They are providing medications, and I'm gonna say something here. I don't know. My brain's not going fast enough here for me to come up with no maybe a little more freer as far as trying to help somebody that's coming down off of drugs or.
Okay.
Dr. Kanos is, and I hate to speak for him with him not being here, but he felt like you should take a little more hard line and not to prescribe a drug to get somebody off of drugs, that type of thing, and I'm not saying that it is a medication. So, but anyway, with Premier Health, I've been very satisfied with their approach to the way they're handling things now.
I only know this from working so closely with the jail. Every jail has what's called a formulary.
Yes.
So even if a medication was prescribed to your son, if it's not on that formulary, they can't prescribe it. Right. But I do know Premier Health because they actually provide services throughout the state. And they also are, I believe, one of the treatment providers for Alva's House, which is also it's not an out of jail, it's a place for treatment for people as opposed to being incarcerated. So Premier Health also provides that.
Okay. Can you comment, Mr. Lawless, on maybe a percentage of the inmates that do have psychosis or psychiatric problems?
Well, I guess I'd be hard pressed to say. I know that as far as drugs and alcohol, you're talking a huge percentage. But as far as a mental illness, I really don't know. I don't. Yeah, it is. The number is going to be pretty high. But to give an actual statistic, I don't know without going back and looking at the computer. That wasn't one of the things I researched before I came here. But if you want to call me, then we can have our jail administrator kind of look those things up through the computer and talk about that.
No, ma'am, I just want to say real quick, and anybody who's a family member and dealing with individuals, there are groups like the Al-Anon groups that help family members. Don't discount your own trauma. Right, going through all this as you're dealing with a family member, because as your family member goes through recovery and as they start to get healthier, bringing that family together becomes very important. And if you dismiss your own trauma, then that becomes even more difficult.
And I believe there is a National Alliance of the Mentally Ill chapter here, NAMI of Lawrence County, if you want to get up and speak to that, because that is the equivalent for those who are dealing with mental health issues within the family. And I so commend you for talking about the trauma that family goes through, because we tend to quickly blame ourselves, right? It's not that simple. And the very fact that you told me, that you told this audience it's been 20 years, I would be concerned about this person's mental health. And so that's a very legitimate concern. Did you want to talk about what's available within the county for mental health or substance abuse? Just 'cause the resource is here. So I think
First, I would want to say thank you to the Herald Dispatch. I'm sorry, the Ironton Tribune. That was a joke. That was a joke. In my personal time, I'm a comedian.
Good.
I know. WSAZ. No, seriously, the Ironton Tribune, because they don't have to do this. And I think that bringing community together, a newspaper, impacts that a lot, right? Also, I would want to say that the people that are supporting the coalition and going every other Thursday, and they're taking their time, they're taking their lunch hour, a lot of them. I think that if you could just raise your hand to let your community members know who you are that go to these. I see several of you back here. And I think that getting that started and supported, and I think that not one person that began to attend those knew some of the voices that began to speak. And I think that we had a lady who came at the very beginning who was a child of an addict, and she was remarkable. And she spoke truth, and she was a young lady who would make you cry hearing her story. And it reminds me that how important our kids are. So what we found, I'm from foster care agency is the tree, okay? And now we have branched off into community mental health for families at NECO. I would say we are only one agency. There's lots of agencies in this community that are working very hard to fight with others to do this. But what we found was we were fighting, trying to help the kids, right? Help the families. And if you can't find enough homes for kids, then you have to go to Plan B, which is helping provide the mental health, helping to address the real problem of mental health. And you just hit it to me. I can tell you that I've got people that I've been in psychosis groups where the individuals did not even know what psychosis was. So I think that you made a really good point about that. Our kids, our families, building families, I believe our faith-based folks that are in the room, you were a very important piece of this. I don't think I'm wrong about that. I know we've got some people on our coalition that represent that. I'm sure we need more people. So I think there's a lot of people with family is the big deal. Your neighbors are your family. Your coworkers are your family. Your politicians are your family. And so not just, who your kids are or who your grandkids are. We got to start looking out for everyone on this. And so I appreciate this panel. I appreciate the Ironton Tribune and that they are able to bring people together because we're becoming more educated as a community.
Yeah, I'm Bob McAllister. I'm a candidate for county commissioner here this year. This has been awesome. I want to thank the Ironton Tribune for putting this on, and you guys this has been just incredibly informative. Through your experience in Ohio and your research, and Judge Ballard, through all the experience you've had putting the drug court together, and Sheriff Lawless, through the experience you've had, are there particular communities in Ohio or West Virginia that have effectively or more effectively dealt with this problem that can be kind of a model, at least, that can help us, inform us in the way we're trying to approach this problem?
So what I'll tell you is, one, I already gave you guys takechargeohio.org. Please go to that site. The other is, we have on the Ohio Department of Mental Health and Addiction Services, it's so long, GCOTE website, we actually have this book called the Opioid Toolkit. And what we did it's changed every year. There are individual programs throughout the state that collectively have done phenomenal jobs. So I'll just give you a couple. The first one was DART. Sheriff Tharp up in Lucas County is the one who started the original overdose response team. That's been replicated. You've already got that. Drug courts, we highlight those. You've already got that. Building a coalition, you've got that. I heard two things, though, that are sticking with me. The transportation thing, Wood County, through Job and Family Services, an auto dealer, which I know I drove by one here, and Children's Services, build a collective. So I'm fast forwarding. The guy who owned the car and gave it to him was able to get a huge tax write-off. They were able to get certified drivers from Children's Services, because those are those who often do transport. And then they had people who were qualified to do treatment but who had no transportation. They would pick them up and transport. That's an example of something that was really creative, completely out of the box to do. But there are steps you have to go through logistically in order to be able to do that. Another county that you talked about the research component, someone brought up research and how you could do it. Universities, and I know that OU is part of this collective. OU, University of Cincinnati, University of Toledo, Akron, they have a collaborative that they've brought together to do research. Now, that gives you free students, essentially, to do research, but they also have the ability to get their hours covered for doing direct service. There's a program called SBIRT, which the physician has unfortunately probably had to walk out for a sec. SBIRT is called the Screening Brief Intervention Referral Tool. But you have to have places to refer people to. You don't open up a wound that you can't close. So if you're going to do an assessment, even if it's a screening brief intervention referral tool, which is about 5 questions, if it comes up that that person registers as, oh yeah, they're at really high risk for addiction, you need to know where to refer them to. And that has been mentioned here, sometimes we automatically assume that people have been habilitated in order to be rehabilitated. That's not the case. We are so far removed from that that you might need some hand-holding, which again, students getting their clock hours. Hand-hold a person to get them to that first appointment. The reason we were successful, and I do brag, I sent this judge, I was like, I'm gonna send you everything we developed for our courts, because no one should ever have to repeat that process. But every county is different. And one of the things I learned early on was bus passes were like currency. Because you want me to get to an appointment, you told me I gotta meet with my probation officer, I gotta go here and drop urine, then I gotta go do visitation, gotta get 2 applications in, I don't have a car. So coming up with a way, hello student, you have a car, we'll just make sure you have the highest rate of insurance, we'll reimburse you, we'll turn you into an Uber driver, whatever it's gonna be. So if we do that assessment and it shows that this person has a need, I need someone to handhold them to that first appointment, preferably a peer support with a student, so it's something that the student is learning from the peer support. But those are creative things. If you go on our website, that opioid toolkit will break it down, and it's not just what can communities do. There are family members or friends who are like, I hear what you're saying, Andrea, but I'm done. I have exhausted every bridge I've held. I'm no longer enabling, but I'm done. Don't try and make me feel guilty. I'm done. Oh, no, I'm not trying to make you feel guilty. I'm trying to get you support. Here's what you can do for your family member. I've done everything I can do. All I can do now to protect my heart and to protect you is give you this resource. If you want, you can call up Judge Ballard, you can call up Josh, they'll help you. But I can't do this anymore. But Andrea gave me this for me to do for myself. So I think that going to that toolkit is helpful, but it also sounds like your coalition might have some really strong ideas or have developed some over the course of this evening, that now it's time to break down into subcommittees to see who's going to do what, who's going to execute what part of the plan.
Also, I'll make sure that the website and these resources will be in the paper and on our website, and we'll make it a part of our email blast so that it's there all the time, so that people know that they can go there.
Right now.
You're awesome. I'll also give you Judge Ballard's home number and his cell number. So,
all right.
Ask for Josh.
Yeah. Just real quick, I want to address the research issue. We're doing a lot of research with this community at Marshall University. I know we crossed the river, but what are you going to do?
Go herd.
And Marshall University currently has a, Andrea talked about ESPR training. We currently have a grant from SAMHSA, which is a federal organization, to provide free ESPR training. And I think that the grant goes through this year. So any organization that wants the ESPR training and how to respond, let me know, and I'll set it up, and they'll come and they'll train your organization.
And Bob, the networking and the communication between the communities, like I said earlier, we would share any of our model with any other county that wanted to look at it. We're trying to gobble up everything that we've heard that's been successful at other places. And like something Andrea mentioned, Judge Ruddock in his drug court in Clinton County gives out taxi passes. Like they purchase it with court funds, but they have a taxi system in Clinton County that can get individuals to the court. I've applied for an Adams grant through OMAS that basically, if I can tie it in any way to the treatment of addiction, I can use the funds. In case in point, Fairfield County used their grant, this same grant, to fix a drug court participant's car, single mother, had like a $400 repair bill on her car, wanted to make sure that she could get to work and treatment and to court, and they used the grant money to cover the expenses on the car, and it was perfectly permissible under the grant because they could show. So no one community has eradicated the problem, but lots of positive in many communities that we're trying to gather up and share our positive experiences too, just to, you know, one little battle at a time.
Site supervisor with Riverside Recovery. I'm also an addict in recovery myself. One of the things that I wanted to say was to the people running for state office, one thing that I would personally like to see is what West Virginia currently has, and that's a model for the hotline, Help for West Virginia. That's a hotline that somebody who needs help can call. The people who answer that phone call are usually addicts in recovery, so it's helping them with employment, and also they follow that person all the way to the bed that they find them for them. They do checkbacks and everything with that. I think that'd be a big help for this state. My question was more about getting back to drug prevention. I know that in the fall, there was a school in this area who was having a little bit of an issue in sporting regulations and drug testing. It was South Point High School. I'll go ahead and put the name there. I actually reached out to that school and volunteered to come in, speak to the students who tell them at about the same age that I was, the decisions that I made that led me to where I was at that time. And I even came with references from other schools that I had spoke at, youth pastors. It's not something, you know, that I just was on a whim going to do. It's something that I've been doing because prevention is actually where my heart lies. And I was turned away. Do you guys think that there's something that you can do to give them an open door or an open mind to let people like myself come in and volunteer our time to help the kids?
I know personally we get invited to speak at schools a lot, and I refuse to speak at a school anymore if I'm talking about this crisis without someone with me who is in recovery, because that's the reality that you were talking about earlier. I don't want to sit there and talk about what other people experience. I want the person in the room talking about what he or she experienced to reach out to the kids. I think that every one of our schools would be benefited by welcoming, and it doesn't have to be during class hours where we're teaching, it could be, you know, assemblies or after hours, things like that. School boards need to be receptive to the people in the community that want to assist with the problem. They need to be cognizant that there is a problem, and they want to be able to help to solve the problem. And then if you get in that mindset, your very next statement should be, well, then I'm willing to do whatever I can to assist in this problem. And we say all the time, we're going to fall down a lot. You know, it's kind of like the spaghetti approach. We'll throw it all at the wall and hopefully a couple things stick. And eventually we'll figure it out because, like, you know, going back to what Bob mentioned, there's no model. There's no model for success in this with what we're dealing with right now, but we're seeing some results. We're seeing some little beneficial things. And I can tell you first and foremost, I don't know that the educators understand how important the need is to get into the schools and how young we need to get in there. And Todd opened my eyes to a lot of this, but my son, my oldest, just did his 5th grade science project, and what he found out with the 5th graders at Fairland were across the board with the national averages. 97% of the kids in that class that he polled knew that heroin was a bad drug and that you could get addicted to heroin. But 1 in 3 children, 33% of the kids, did not believe you could become addicted to a drug that was prescribed by a physician. and thought it was automatically safe if a physician prescribed it. 1 in 3. And that's what we're worried about. You know, they know heroin's bad, but they don't know what's in the medicine cabinet is bad. So tell me there's not a need to educate. And if you turn away a resource that can help as a school board or a teacher, shame on you.
Make sure you give us your contact information before you leave today.
Thank you so much for taking. Thank you so much for taking your time to come down here tonight. I've watched these grow over this last year, and you folks are doing a tremendous job. My name is Nicholas Landry. I've practiced family medicine in these counties for 19 years, and been doing work with addiction for the last almost 9. And I'm one of those physicians who's come into this county for 2 days a week because we had such a huge demand going up to Gallia County to my primary office, and folks were not able to sustain the transportation. So there's a couple of looming elephants that people may not be aware of that are in the room for me clinically with having success with maintenance and management of people with addiction, and actually in primary care that exist down here that are outside the scope of this community to handle. So we're certified by OMAS, Ohio Department of Mental Health and Addiction Services. We run steps of recovery. We do the counseling. I do the primary care. We offer MAT to those people who are appropriate, which would be buprenorphine, Suboxone, Vivitrol. We don't do methadone. We have a fully integrated program, and I also do the psychiatric management to the level of my ability. So right now in Vinton County, Gallia County, Meigs County, I have nowhere to send people for psychiatric consultation. It doesn't exist. Woodlands folded, Hopewell took it over. They don't have a psychiatrist available for months, and I think that exists in Jackson as well. Down here, we have access on a walk-in basis with Shawnee. There is another organization. I'm waiting on CareSource Medicaid to get back to me with other resources they said that they believed existed, but I haven't heard from them. Now, this becomes very prominent because SAMHSA actually announced at the National Conference on Addiction that I went to in July in Dallas last year, and I've known this for years, but they finally got on the podium and said it, that you have a 100% failure with addiction management if you do not manage co-occurring mental health. And the majority of people with addiction have mental health disease and or other disorders. Telepsychiatry, people are grossly resistant to. We've tried for years and I know it's the next best thing to have in a live doctor. I'm thinking that, you know, maybe we could get some potential grants drawn up to buy a psychiatrist, bring a psychiatrist down here, probably a couple of them. We need them. This is beyond my scope in primary care, and I'm actually quite good at psych, but I'm not a psychiatrist. Yep, Nicholas Landry, D.O. Yes, ma'am. So I don't want to dwell too long on any one subject because of time and trying to respect everything here, but we are not going to succeed with addiction management if we cannot consistently diagnose and maintain support and medical management of mental health. So, number one. Number two, missive came out which quantified my greatest fear coming, but I got to back up a little bit before I deliver it. So in meetings before, I think we represented there's around 1,100 people employed in the county. This county, like the surrounding counties here in Southeast Ohio, is grossly dependent on Medicaid support. So the majority of patients are Medicaid patients, some Medicare, and of course there are some insured individuals. The bulk of the cost share of addiction management is Medicaid, period. Now, the missive that came out from OMAS, the Ohio Department of Mental Health and Addiction Services, was that the issue coming to the table right now is Obamacare is expiring. So Obamacare was fueled economically to the states that accepted funds, and we were one of them here in Ohio. Extrapolation of the data that OMAS released from Scioto County, and I don't know the statewide numbers, but they're probably going to mirror it roughly. Approximately 23% of the Medicaid recipients in the state of Ohio are funded by those Obamacare dollars, which expire December 31st this year. in January, those funds won't exist. The state can't come up with them. And we don't have a direction of what we're going to do, but that population, right now, that's not happening. So, right. Correct. So my question is, can we get some support of that in Columbus, number one? Please, because we're going to have lots of people destitute. And we're talking about diabetics and other people in medicine that don't have access to care. And so that's number one. Number two, a few years ago, Medicaid disbanded disbursement of Medicaid to managed care plans. We're mostly aware of this: CareSource, Molina, United, Paramount, et cetera. It was an idea to be cost containment and get better delivery of care with management. Those plans, in turn, each have vendors for transportation. Now we're getting to transportation, big problem. And I don't think people know about this outside the communities that are suffering. Those vendors pick and choose who they want to hire to do transport for Medicaid recipients. And they limit who they are going to take on board. We have had patients for years that Medicaid transport companies hired by these vendors exclusively are not doing the deliveries of patients or picking them up.
What is the question?
So can we get this looked into? Because we've had patients abandoned at offices, transport doesn't pick them up. I've had counselors driving as far as Jackson County and Waverly to bring patients home at 8 o'clock at night. Mm-hmm. Mm-hmm. Last question is that the Medicaid plan representatives don't exist here in Southeast Ohio. No, actually, no. I mean the representatives for CareSource, Molina, United, the plans. They don't come here. They spend all their time in the metros where they can go to many, many doctors' offices in short periods of time and have their numbers represent that they're doing their job, seeing a lot of doctors, helping with gaining access to care needs. In these rural counties, the offices are spread out, and they can't hit as many people in a day and in a week. And this is all numbers. And I've actually been told this. We can't see very many doctors down there. We got to meet our quotas. So I can tell you, I can't even remember when I last saw representatives from 2 of the plans. I finally talked United into coming into the office tomorrow. We can't get these and other needs met when we are not getting any representatives from the Medicaid plans hearing us and coming to see us. Just like the physician in the back doesn't have anybody that she could talk to probably either. I've talked to peers and colleagues.
We were provided a forum where most of those plans were invited by the state, and we had select physicians within the area attend. That would give you a forum to talk about.
It would, but their protocols are their reps are supposed to come to our offices routinely to see us. I agree. Anything is great for access. Thank you.
If they're not talking to you now,
Yeah.
we at least make them come to a table.
Be wonderful. And then that's a cascade of all other things that we can work out through them.
So I'll start with that, and you'll receive an email tomorrow.
Okay, thank you. We will be having other forums, as you can tell from the time, that this is a big issue. So we'll be having other forums, we'll be having other speakers, but please thank this group of speakers. They've been amazing. They're on the front lines, and they deserve all the applause, as do you. Thank you.